Okay, so this is the first case. It's a 30-year-old female. You can see that she's had a prior sleeve gastrectomy, which actually I haven't seen one that has like this many clips. Or I don't know, yeah, it looks like a lot of surgical clips, but anyway. And then there's this lesion. So what do you guys think about this lesion?
What are the age? Sorry.
30-year-old female.
So if it is from pancreas, then probably Spain.
Okay, good thought. Here's the pancreas. It's, it's touching the pancreas. I can show you the coronal. But
coronal, please. Yeah.
Yeah, it's pretty exophytic.
Oh, no.
Not completely claw sign there. More like pushing it a little bit.
Maybe exophytic cyst then.
Okay, good thought. Let me go back to the axial. So you're thinking it may be coming off one of these bowel loops. Good. It does look like retroperitoneal to me. But the duodenum over there could be, but I don't know. I see kind of a plane here. Is anything else?
Maybe
Nerve sheath or exophytic renal.
Okay, so that's a good question. So do you think it's coming from the kidney or not?
No claw sign, but occasionally, I've seen here it looks like it's compressing the renal parenchyma more than claw sign.
Yeah.
Maybe from capsule, maybe sarcoma from the capsule.
Exactly. Capsule is a good thought.
Okay, good thought. Anything else for retroperitoneal heterogeneous mass?
Nerve sheath.
Good.
Nerve root.
Yep.
Schwannomas or
Maybe
Okay,
extraduodenal paragangliomas.
Yes, good. Paraganglioma is another good one we should think about. So anyway, this at an outside hospital, this was called a exophytic renal cell carcinoma. And they thought this would be a really nice one for a robotic laparoscopic resection, given how exophytic it was perceived to be. They attempted the robotic resection and the patient's blood pressure went through the roof. And they actually ended up in the ICU and they got Takotsubo cardiomyopathy.
Wow.
And they aborted the surgery, basically. So clearly this wasn't an RCC. This was actually a paraganglioma.
It looks separate.
So teaching points here would be, we don't really see the claw sign. Don't forget about paragangliomas, especially this. They like being heterogeneous. They like being mid-sized like this. They love having cystic spaces. Although RCC can definitely do that from necrosis, but a lot of paragangliomas have that. So just don't forget about them. If you think it might be one, it's really important to bring that up so that they can alpha block them before they go to surgery. This ended up being resected later after they alpha blocked them, and it was a paraganglioma.
So
Can you hear me?
Mm-hmm.
It looks separate from the kidney.
Yes,
Doesn't
good. Yeah.
Sorry,
so,
I came in a little late, so you guys might have already discussed that. Sorry.
yeah, people were saying like, could it be from the capsule or could it be exophytic? But yeah, Nelly, you got it. So it's really not from the kidney. And so, I haven't actually seen one that would be this exophytic, like a renal cell carcinoma. So I think that is the correct way to think about it, Nelly. This is not from the kidney. It's just compressing it. And so we really have to think about the other retroperitoneal tumors. And paraganglioma should be like way up there.
So the one question. So how sensitive are the metabolite tests or like blood labs to exclude if it is paraganglioma?
I think especially if it's functional, they're pretty sensitive. I don't know the number, but that's basically the order of things which we would do things. They would do blood like VMA and catecholamine. And if that's elevated, then basically they would say this is a presumptive pheo or paraganglioma. If that's not elevated, but we're still suspicious, what do you think we could do next, imaging wise?
Like MIBG?
Yeah, so it used to be MIBG, and actually my next case is a good correlate to this, but now they say dotatate is even better. So dotatate is really good for neuroendocrine tumors, but it's also superior to MIBG and FDG PET for paragangliomas. So the next step I would think is and especially if the patient is hypertensive and you're really suspicious, I would think a dotatate would be next. If that is still negative, you could consider biopsying it. We have biopsied pheos. Usually those are the ones that are not hormonally active, so it's safe to biopsy them. If they were hormonally active, they would have like already increased your metabolites. So,
Interesting.
and let me just show you my companion case. Okay, so this is a patient who had a prior pheochromocytoma resected, and now they have multiple. This is a Dotatate PET MRI. So I showed a couple of PET MRIs last time we're doing them. You can use any agent. So you can do like PET MRI with FDG, you can do it with Dotatate. So this is a Dotatate one. We can see that there's a lesion here. There's one in the pancreas. There were multiple lesions in the liver here. So this was a patient with a prior, known paraganglioma, and now we can see that there's multiple metastases. So PET MRI with Dotatate is really good for mapping of metastatic paraganglioma. And it's also really good for surveillance of people with hereditary paraganglioma syndromes. So I think Nelly talked about one of these before, but there's a lot of different paraganglioma syndromes, and several of them have this SDHD mutation. And then there's other syndromes that also can have paragangliomas, and that includes von Hippel-Lindau, neurofibromatosis, and MEN2. So for people undergoing surveillance with those syndromes, you could consider doing a Dotatate PET or PET MR. And like I said, it's basically now superseded MIBG and FDG PET. Okay, and then I have one more case. Okay, this one is a patient who underwent an EGD, and they found a little duodenal nodule, and it came back a neuroendocrine tumor. We were kind of doing a staging MRI, and we didn't see the primary duodenal tumor, but they were looking for metastatic disease. We didn't see anything in the liver, but we saw this lesion in the spleen. So I'll show you this lesion on a few different sequences. So it's very faintly T2 bright. It's pretty ISO on the pre-contrast. It is very avid, avidly enhancing on the arterial phase. And basically blends in again on the delayed phase. So this patient has a known tiny 2 millimeter biopsy-proven neuroendocrine tumor in their duodenum, and they have the splenic lesion. So what do you guys think about the splenic lesion? Go back to the arterial phase where you can see it better. Any thoughts? Do you guys think it's a neuroendocrine met? Do you think it's a benign lesion?
Yeah, most of the solitary incidental splenic lesions are benign, and also it would be unusual for the met to be so much larger than the primary tumor. So I would favor a benign etiology for the splenic lesion.
Excellent, excellent. So that is what we should do. Like you said, most primary solitary splenic lesions are benign. And there is some characteristics about this that point towards a specific lesion, which I had to kind of look up, but I'll just tell you kind of what happened, which is basically because we saw this and it was raised that, we can't exclude a neuroendocrine metastasis, given neuroendocrine tumors like to be arterially enhancing and kind of blend in on the delayed. Like if you saw that in the liver, you'd be very suspicious. But like you said, it's way out of proportion to the primary, which was like a tiny 2 millimeter thing. And it's unusual for to get like a solitary met to the spleen. So they were still confused. We said we couldn't exclude a neuroendocrine tumor here. They did a Dotatate scan. And you can see that there is uptake greater than the background spleen in the lesion. So what do you think now? Is this a neuroendocrine met? Can other lesions take up Dotatate, or is it just neuroendocrine tumors and paragangliomas?
Increased uptake could just be from it being hypervascular.
Yes, Good, excellent. So this was read as possibly still can't exclude a neuroendocrine met, and it was resected, and this turned out to be a hamartoma. So going back to how it looked on the MRI, this appearance actually, and I was reading up on it, is actually kind of classic for a hamartoma. Hamartomas are basically disorganized splenic tissue with more red pulp. So they tend to blend in on a lot of sequences. And so it blended in very nicely on the pre and the T2. And it tends to have this more avid arterial enhancement and then blend in on the delayed. It can look like a hemangioma. They can be similar, but the hemangiomas tend to be T2 brighter and they have more progressive enhancement, similar to like a hepatic hemangioma with like the nodular peripheral enhancement, although it can be flash filling like this. But to Anu's point, basically both, even hamartoma or hemangioma, doesn't matter. If you bring up both of those, that would be the appropriate kind of differential here, because they're both benign lesions. And then getting to the dotatate, I was reading that basically there's lots and lots of false positives on dotatate. Up to 15% of lesions found on dotatate can be benign lesions. Anything expressing certain somatostatin receptors can be avid on dotatate. So some common things that can be avid are accessory spleens or splenosis, the uncinate process of the pancreas, where there's a higher degree of somatostatin receptors. Actually, I'm not, maybe. Oh, this might have actually been the primary duodenal tumor. But the uncinate process is a common false positive. And then inflammatory processes like postoperative, post-radiation, meningiomas, schwannomas, and then various benign bone lesions. So just because it's hot on dotatate, don't jump to the conclusion. And splenic tissue has somatostatin receptors. That's why it takes up dotatate. And so if you have a hamartoma, which is just disorganized splenic tissue, that can also take up dotatate.
But in this setting, since you had already seen that there was a neuroendocrine tumor and this was the part of this workup, would you have still, would you have been confident in hindsight knowing that this was a hamartoma, or would you have just said, still question it?
Excellent question. I don't know. I wasn't the one actually reading it, but that we kind of hedged. We said like can't exclude. So that's why they ended up resecting it. I guess one thing you could have done is biopsy it, but that might have been tricky because it might have been, hamartomas looks like splenic tissue. So they might have said like, oh, you missed the lesion. I guess I think Anu's point is the most important. Like this seems like a very unusual pattern of spread to the spleen, and splenic lesions are common. And the thing that I learned now is like, don't just jump to met if you see a hot on dotatate, So I think putting together all the three things, I would have said like, this really could still be a benign lesion. But that's kind of why I'm showing it here, because I didn't know. And actually the patient had a splenectomy. So I'm not sure, what anybody else have any other thoughts?
I wondered if we could have offered biopsy rather than removing the spleen. We've splenic lesions.
Yeah. And I think just increasing awareness about like what a hamartoma kind of looks like, because I don't know, I've brought it up before, but I didn't know like if you look on Radiopedia, it says like basically exactly how this looked, which is that it's kind of like iso-intense on all other sequences. And then it's arterial enhancing. And then also that would have been unusual to just have like a solitary met there. So.
Can you show the T2?
Oh yeah, sorry.
I guess if it was a neuroendocrine met, it would be like T2 gray, right?
Yeah, and actually
I guess it depends. Yeah.
Now my PAX is frozen, but it was very faintly T2 bright, and it was very faintly higher restricted diffusion than the spleen. So it was like kind of mimicking spleen on most sequences. I think it's like in retrospect, I think like just statistically, it would be weird to have like one big neuroendocrine met in the spleen. You know what I mean? From like a small duodenal thing.
Oh, and the other, like, was there a change on compared to prior, or it was just the first study because
this was the first study
newly diagnosed? Oh, got it.
Yeah. And then we thought like the dotatate would help clinch it, but in fact, the dotatate was like a false positive. Okay. That's it for me.
Can I present a case? Oh,
yeah.
Sorry.
Yeah, go.
Oh, can you pause? Would you be able to pause that thing?
Yep.
Okay. This is the patient with history of HCC. They've had prior local regional therapy, and these lesions have been followed for transplant evaluation. And so these lesions are LRTR non-viable. So we've just been following sort of just a serial imaging, to follow that. And so this was a subsequent imaging. I'll let you look through that. And then this was done a few months later, just part of the screening. This is what it looks like. And then here's another imaging that came after a few months later. This was not.
It's interesting that you guys switched from MR to CT.
Oh, it wasn't done here. It was done
Okay.
elsewhere, and we're just giving outside interpretation reads for the transplant evaluation.
I'm
so
finding the
it's-
CT much more difficult to read, but there's all this
Agreed.
build.
Yeah, exactly. So and then and the patient had an MR.
There's like new lesions obstructing the biliary tree.
Yeah. And what do you think about that lesion?
Show the arterial phase.
Here it is.
That's the arterial
Hypo.
phase.
Yeah.
Oh,
It's like, it was kind of early. It's not ideal. It's kind of early.
but I would say
Oh,
at
actually,
this
it's not
point it's like
bad.
an LRM.
Yeah. This was biopsy and it was cholangio. So the teaching point is that looking for that, like it was, if you look back, it was you started to see so this was normal. And then over time, the ducts got a little bit more prominent over time, and it was really slow. And I think when you start to see kind of, the dill kind of getting worse and worse, but very slowly, I think that we would have to, raise some kind of obstructed lesion. And it's, I think in retrospect, you can kind of see something here, but it's kind of limited because of the type of exam that we got, not we, but that was gotten. And on MR, it's a lot more discreet. So
Yeah, I feel like the other teaching point is like MR is better than CT.
always.
I'm waiting for someone to to argue with me.
Pretty much the truth.
So yeah, just be wary of these very subtle dill that can kind of later surface as something bad, like a cholangio in this case.
Okay, Victoria, you're up.
Okay, where's the share screen? So this is just none of my cases are very long. So this one was a sad and kind of and teaching case. This is a young woman, 40 years old, who had a sudden cardiac arrest when she was just walking on the boardwalk. And luckily she, there were some policemen around, so they initiated CPR, so she survived and she's in ICU. And they did a CT originally. There were some questions about, heterogeneity of the liver, so they decided to get CTA. And this is the liver. So you can see that, the left hepatic lobe just is, shattered really. There's discontinuity of the capsule. When we go up, we see that she had broken ribs, which is, we all know about broken ribs from the CPR, but this is something that I didn't know about, that up to like 0.5 to 3% of CPR recipients get liver lacerations. And it's specifically going to be affecting the left hepatic lobe, which makes sense. Kind of, so this is kind of like, I've never seen this before, so I figured I'll show it to you guys. And she was stable actually. So the CT from 2 days before, you can see this, there was some perihepatic fluid. So this, so degree of fluid or amount of fluid didn't really change that much. And then she wasn't really bleeding at the time of the study. So I don't think they're doing anything for this laceration, but it's pretty pretty significant liver laceration. Any comments?
I haven't seen that either. It makes me wonder, I mean, it makes me think like maybe they're pushing too low, but I have to brush up on my CPR
Yeah.
technique.
I mean, well, I looked it up because I didn't realize you can actually get this done. And apparently it's not a common complication, but it's a fairly known complication.
Yeah.
And
isn't there some like really scary statistic about like how many patients don't even survive CPR? So like maybe we're just not imaging a lot of them that have liver infections.
It's the fact that she made the fact, I think only a third of people who collapse, who have cardiac arrest outside the hospital, get to the hospital, and a third of that walks out of hospital like intact. So she beats the odds for being alive, and last time I checked, she was actually waking up a little bit. So hopefully she'll survive and be okay. Okay, so the next case is so sorry, the PACS is a little bit. So this is a gentleman who came in around Christmas time, and his history was that he's bleeding from his rectum, and this was a very obvious bleeding from the sigmoid, right there. And I'd like to, point that everything else kind of looked okay in this man. This, gallbladder had a little bit of gallstones, but nothing else was happening. So the patient had angioembolization of this, this bleed, and 2 days or a day after, exactly 24 hours after, we had a lot of abdominal pain. So they decided to get a KB, which is right here. So I would actually like to see if you guys can find the finding, because I missed it. I read the KB. It was a very busy all day. So, but even if it wasn't busy, I don't know if I would have picked it up. So I'm just curious if you guys can see the finding.
Pneumatosis?
Huh?
Pneumatosis on the right lower quadrant?
I can't hear you.
Is it pneumatosis on the right lower quadrant? I see.
So let me show you the follow-up CT. So the CT was done. This would be like 12 hours after the KB. So this is like the CT is 36 hours after even less than that, after the original CT. And there you go. So that you can see the gallbladder is markedly abnormal right now. There's air in the lumen and in the wall. So this is emphysematous coli. So two interesting things here are, first of all, like here, I'll extend the field of view so you can see this is 36 hours. And obviously because of the KB, you can, even 24 hours after original CT, you can see how quickly gallbladder can die.
Yeah, I think on the KUB, you could see that linear thing in the right upper quadrant.
So in the retrospect, I'm like, oh, wow. It was present right here. Obviously, once you know it's there, it's like right there in your face and you can't miss it, but
yeah, there it looks so like linear, like not bubbly.
I know, right? So, but it sort of kind of looks like that. If you look at the coronals on this CT, it does look like that there, right? The interesting part is that he also had pneumatosis. He had, in addition to having a necrotic gallbladder, he actually developed a pneumatosis right here. You see it? So at the side of his embolization coils, you can see that he has also pneumatosis. So he had both ischemic bowel and necrotizing cholecystitis. And coincidentally, he had, retained, ATM from contrast administration.
So is the theory that like when they went in to do the angio, they flicked off some plaque into cystic artery? Like as
so
it
I
went
don't-
through the aorta and like into the celiac
I don't-
axis or something?
So I don't have a theory as to what happened to the gallbladder, but I was actually shocked that it can go from normal to this in 24 hours. I think the theory for the colon is that the embolization, as a result of embolization, they cause ischemia. So I assume, yeah, something along the lines of what you said, that they coincidentally dislodged something that knocked out cystic artery. Yeah.
Yeah, because it looks like he has a lot of calcified plaque here, but maybe there's a lot of also non-calcified plaque in the aorta.
I mean, here's the, didn't look that bad here, but something happened, or there was maybe what do you call it, low flow state, but anyway. So I don't exactly know, but I mean, again, like I've never seen the necrotizing, the gallbladder necrosis happen this quickly. It's pretty interesting. All right, so the next is a young woman. She's 22. I'm going to withhold a little bit of a history. And she got an MRI. Well, I'll just say the history was tenderness in like periurethral, anterior vagina. So that's the history, right? So just some tenderness at the periurethral region / vagina. So incidentally, she has a pretty unicornuate uterus. You can see here. You can actually, one thing that was here that was cute is that you can actually see the collapsed cornea right here, with the fallopian tube coming through the cornea here. So we don't get to see that often, but this is very pretty. And notice that there's no such thing on the other side because it's a unicornuate. So, we've kind of found that everything else looked good. So we're about to close the case. And then
Victoria, I have a question about that junctional zone up there. Would you call that like focal adenomyosis there?
Not when it's like that, because sometimes I've seen this and it's often related to like focal contraction. So unless I see it like persistent on multiple, I wouldn't. And like here, this is a T2, sagittal T2 acquired a little bit later, and you can kind of see that it's sort of resolved. So.
Oh, cool.
Yeah. So, yeah. Anyway, so I was about to close the case, and then we saw the history and just started. Let's take a look at the periurethral region. On T2, not that impressive. Oh, sorry. Here's the coronal T2, kind of maybe a little bit asymmetric right there. So the interesting finding was on contrast. You can see on post-contrast, clearly there's abnormal enhancement there, right where they are kind of, saying the patient is tender. So I really didn't know, like there's some sort of abnormality, right? In like periclittoral, this is like in the region of the clittoral hood kind of situation. So, and then on T2 with fat side, you can see there's like a little bit of kind of inflammation there. Anyway, so we ended up kind of calling it lichen sclerosis because it's the best that I could have come up of all the things that happened. And when we start looking through the chart, it sounds like that fits the clinical picture as well, because they've kind of looked at the vagina, and there was like areas of patchy atrophy, which kind of goes along with this lichen sclerosis. So I don't know if I'm right, but this is, if anybody has any better thoughts of what this could be, I'd be glad to hear. Based on the clinical,
I think it's a reasonable diagnosis.
yeah. I mean,
supposedly we underdiagnose it, like males can get it too, and we kind of underdiagnose it. It can be a really debilitating source of like pain and itchiness, and
right. I
it's
mean,
like a skin disease that is going into the urethra.
So it's like based on her symptoms, it's right exactly where she's feeling pain and itchiness. Based on the physical exam, it kind of fits together. So I'm going with lichen sclerosis, but disclosure, I don't have a path for this one.
And they can biopsy lichen sclerosis.
Well, they may end up biopsying. Okay, so this is my last case, and this is I don't remember why this patient had this. I think there was it's a follow-up MRI. It's just a very interesting finding that we don't often see on MR, and that's this thing. And this is right there here, and this is MR appearance of a gastric ulcer. So you can see that here, you know, a lot of kind of thickening surrounding the tract with kind of almost like a fibrosis appearance right there. You know, patient was treated, ulcer went away slowly but surely, but this is like a really cool appearance that, you know, I've never kind of seen before on MR.
Yeah, and I think that's like a blind spot often for us. People often don't look in that area, but did it stick out on diffusion?
Well, diffusion, I'll show you, not quite, but wait, here we go. So you can see that the clue here also is that, you know, you have blooming on the long echo of the, you know, phase of the acquisition of the gradient echo sequence. So that's like a little air kind of cluing you in terms of diffusion. Let's see. Yeah, it's, yeah, it's hard to judge because of all the nonsense that's happening here. Anyway, but this was, you know, this was confirmed with you know, with endoscopy. You can see it right here, and then patient was treated, and patient is doing okay, and everything is gone. There's just a little scarring there. Doing follow-up studies. That's all. I thought it was like a very interesting finding that we don't often get to see on MR or on any, you know, cross-sectional images. Really, you can see here that the liver is, you know, kind of reactively hyperemic. You see a lot of hyperemia on arterial phase related to this. So it's pretty cute.
One question, Doc. So can we differentiate benign versus malignant gastric ulcer?
Oh, you touched upon my biggest, well, one of my biggest pet peeves. Yes, because malignant, and Aarti, if you disagree, you jump in, but my take on this is malignant gastric ulcer is a misnomer. It's not really the ulcer that becomes malignant, but it's the malignant mass that becomes ulcerated. So, you know, on CT, and I haven't seen that on CT, but I have CTs, and you can actually, you can see a mass, right? You can actually see sessile mass with large central ulceration. So all the things that they teach you on, you know, on upper GI, how to differentiate benign versus malignant ulcer, you can actually see on the cross-sectional, like how they come about, because malignant gastric ulcer is ulcerated gastric malignancy. So you will have a mass with a central cavity. So the cavity will be projecting into the lumen of the stomach rather than outside, right? So here, all this hole, right, is all outside. So that's a feature of the benign ulcer. You don't have a mass here. You have like hyperemic mucosa extending to the ulcer crater. That's another sign of benign ulcer as opposed to malignant. Like even on T2s, you can see it nicer, right? Here, right? There's no actual mass here. There's just thickened hyperemic folds. And the ulcer crater extends beyond the confines of the gastric lumen. So things like that. But the key thing is for malignant gastric ulcer, we will actually see a mass with a central ulceration, and everything else will follow from that pathology.
Thank you.
Aarti, do you agree?
I agree. Yes. And actually, as a resident, I never understood that whole concept about like projecting beyond the lumen or in the lumen. I think you just described it perfectly. Like it's, yeah, the mass will be heaped up, and so then the ulcer will be in there. So if you, on fluoro, it doesn't really extend beyond the wall,
right?
Expected edge of the wall.
Right, but if you once you see it nicely on the CT, it's like clicks. I'm like, oh, that makes a lot of sense. Like why all the things that you have to remember for upper GI just totally makes sense when you see it. Nice example on CT. That's all I got.
Awesome, thank you. Anu.
Sure. Can you pause recording for a minute, please? Just a minute. Where is our Zoom window? Okay. All right. So this is a young lady incidentally found to have a pelvic mass on ultrasound, and therefore they sent her an elevated CEA levels as well. And so she was sent for staging CT. This is an older case, not a current case, but I thought it was interesting. So here you see this predominantly cystic mass in the left hemipelvis. And then incidentally, they noted that there was some bladder wall thickening, which I'm going to show you in the coronal plane right here. Sorry, my window. All right. So here it is. The bladder is not very well distended, but you can see an asymmetric focal wall thickening right here. She didn't have any history of hematuria. This was completely incidental, in addition to this cystic left hemipelvic mass here. So after the CT, rightly so, people were concerned that this is a urothelial malignancy, and the cystic mass here was, the differentials provided were serous origin, youngish lady, serous cystadenoma, or serous tumor arising from the ovary. And so after the CT, she went on to have a cystoscopy. And before I disclose the cystoscopic findings, I'm going to show you what the ultrasound showed. So let me pull up the ultrasound images here. So this is the bladder, again, left jet, and you see the bladder mass right here. This mass is in the dome, as we saw on the CT as well. It has some cystic components within it. There was a little bit of vascularity at the base of this lesion, fairly large mass. And then I'm going to show you the pelvic MRI as well. Let me start off with the SAG. Okay, here we go. Very dark with T2 bright foci within it. Right here. Let me show you the coronal T2. There is T2 bright areas within it. And then I'm going to show you the axial pre-contrast T1. So this is the FATSAT pre-contrast T1 weighted axial sequence. I'm going to try and reconstruct it in the sagittal plane. I know the resolution is not great, but never mind, there may be another one. Anyhow, on cystoscopy, the lesions were, they saw a bulge at the dome of the bladder corresponding to this area. And they saw some bluish discoloration underneath the mucosa. The mucosa overlying it was absolutely normal. And this was an entirely submucosal lesion hidden here. So any guesses?
Kedar in the chat said endometriosis, which I also agree with.
Indeed. So this was, and the pelvic lesion, left hemipelvis, was a large endometrioma. I didn't want to show you the ultrasound to give it away at the beginning, but this was indeed involvement of the bladder with endometriosis. And the urinary tract as such is can be involved in a small percentage of patients with deep infiltrating endometriosis. Bladder is the commonest, followed by ureters and then the kidneys. And the bladder as well, the common sites of involvement are the trigone or the bladder dome. And again, in terms of management, one needs to distinguish between involvement of the detrusor muscle, because then that would go to partial cystectomy or resection, versus just shaving off of the lesion if the lesions are superficial, not invading the detrusor muscle. But having said that, making that distinction of involvement of the detrusor muscle, intrinsic versus extrinsic, can be very challenging on imaging, given that the bladder wall itself is so thin. So I just thought this was a nice case of, other than ovarian endometrioma, there weren't any additional findings of DIE in the pelvis, and this was an isolated bladder dome involvement, patient being completely asymptomatic. So interestingly, they're still following the bladder lesion. She's on hormone hormonal therapy, etc., but didn't opt to go in for resection. So that's my first case. And then if you pause.
That's a huge one.
That's a huge one, exactly.
I've never seen one that big, but I had a similar case where it was going through the mucosa. So they saw it on cystoscopy and they thought it was like a fungating mass. They did biopsies and it kept coming back fibrosis. And they were like, but this looks like a malignancy, and it came back fibrosis. But then we looked on MRI and we brought up endometriosis, and they went back and restained the fibrosis for PR receptors, and it came back positive. So that was an interesting case to me, because the initial, I guess the endometriosis wasn't even super obvious on the biopsy unless they do that extra stain.
Right. And also there is fibrosis, right? The cyclical bleeding induces fibrosis. That's why it's so dark on T2. So
yeah, just like, but on pathology and cystoscopy, they didn't suspect that. You know what I mean? Like they, so we have to bring it up, you know?
Absolutely. So I feel like radiologists play a huge role in initiating that conversation and making the diagnosis. And MR has a very high sensitivity as well as specificity in detecting bladder and endometriosis, or any endometriosis for that matter. So that's one. And then if you pause recording, okay. All right. So this is a companion case to the spleen lesion. And, you know, before I start showing the case, I want to disclose that they have not had a splenectomy yet. So I really don't know what this lesion is. I just saw it yesterday. So they might undergo splenectomy soon. So this is an older lady, incidental splenic lesion. She had a CTPE for dyspnea, acute onset dyspnea, and they saw this splenic lesion back in May of 2021. And then subsequently, I have an MRI from December 2021. I don't know what happened between May and December, but oh, hold on. Before this December, there's another MR. This is the most recent one. Yeah, I guess we can see the December one. So December 3rd, 2021, there is a pleural effusion here. And this is the splenic lesion now. It's huge. Since May, it has really increased in size. You know, hold on a minute. I think there was another MR in between sometime where they tried to characterize this. This is December, May.
What about the
first one? Yeah, yeah, exactly. Backtracking, this is an MR from June, soon after that CT, when it was found incidentally. And as you can see, this lesion is very heterogeneous on T2. There are some areas that are bright, but it's not cystic. It looks solid, if I may say so. And the size is comparable to what we saw back in May. I can just go through some of the sequences. This is the diffusion weighted sequence on the ADC maps. The rim shows some restricted diffusion, but not really. And then post contrast, this enhances more like a solid, it shows a solid rind of enhancement. But as we know, the central portion, even though it doesn't enhance, was not fluid bright on T2 weighted images. And then let me jump straight to yesterday's or the most recent MR, and then yesterday's CT. So just in a few months, it has increased dramatically in size. Similar features, very heterogeneous, intermediate to bright periphery within the lesion, not cystic. You know, I won't go through all the MR sequences because they're very similar to what we saw on the original. The interesting part is now she has a new left pleural effusion, and there are areas of discontinuity between that mass, the capsule, and perhaps the diaphragm. It almost seems like it has ruptured into the left pleural space. It's certainly much larger. You can see this exophytic component within it. If I had seen this in isolation without the MRI, I would have thought this is like a cystic splenic lesion. You know, we've seen previously I'd shown a case of an epidermoid cyst like this that had ruptured into the peritoneal cavity. Very similar, multiseptated. This is what it looked like on CT, but because we have an MR as well, we know that this is not purely fluid bright cystic lesion. So any thoughts on what this might be? I don't know. Like I said, I will give a follow-up on subsequent in our sessions in the future whenever the spleen comes out. But there is a plan for the spleen to come out.
What was the enhancement?
It's like this multi-septated.
I'm thinking like a sarcoma, maybe even an angiosarcoma. That it looked to me pretty ugly on that June one. Like, do you know what it was called in June and like why?
Yeah, I don't know. These are outside hospital scans. I do not have any reports on them. I mean, if I dig into, perhaps I can look at the reports. I'm sure I can bring up the reports. Not sure what they call them. I agree. I was thinking of the same, given the rapidity of growth and the solid look of it, but I've never seen an angiosarcoma rupture with, maybe it's just a simple reactive pleural effusion. I don't know.
I mean, to me, it looks like it's invaded through the diaphragm and therefore like you can get the malignant effusion. I'm not sure I would say rupture, but it definitely seems like it's invaded through the diaphragm.
Yeah. The pleural fluid hasn't been tapped. We don't know, but so not all solitary incidental splenic lesions are benign. So, contradicting that statement, earlier statement. But I'll certainly give all of you a follow-up. It looks ugly enough. Angiosarcoma is a great thought. And there's nothing else in the abdomen, you know, not a met or anything of that sort.
Yeah, I think it's going to have a bad prognosis though.
Yeah.
Given how like aggressive it looks and rapidly growing.
And too heterogeneous to be lymphoma. That's another primary, among the primary neoplastic lesions of the spleen. You know, angiosarcoma is definitely the most aggressive one. Then the other things that can be seen are lymphomas. Although secondary involvement of the spleen by lymphoma is more common than primary splenic lymphoma, but stay tuned. I'll give you the follow-up.
I have a quick question and comment about this case. So the question is, what was the thought process between, like after the second study? Because in the second study, we see definitely rapid growth compared to the first one. So they still wanted to go for follow-up rather than resection?
No, so the study that showed rapid growth is the most recent one. So they're already planning for resection, and that one was December. So I don't know whether the 1 month delay between when they noticed that it's very aggressive and has grown, is that 1 month delay, has it been influenced because of the current situation, you know, with the pandemic and getting people to surgery, etc. I don't know if there was a delay there, but currently they are on the list for surgery, given the pleural effusion and things like that.
Yeah, the comment is definitely like sarcoma would be the first, but only looking at the CT particularly, I would also raise concern about hydatid cyst if the patient is of, the demographics fit. Though the liver and lungs are not involved, but sometimes hydatid cysts.
Yeah, that's what on CT, I agree. On CT, it looks like a multiseptated cystic lesion.
Yeah.
Wouldn't have known that it has such features on MR. Purely.
Yeah, we even had a huge splenic abscess that looked very similar. Okay, you'll have to give us the follow-up.
Definitely. Pause, share, and mute.
Yes.
So this is an ICU patient. Patient is 47-year male, and the requisition rates as decrease in hemoglobin, rule out retroperitoneal collection. So we have multiple findings. So it looks like bilateral pneumonia, refusion, and some ascites. And the patient's kidney function was bad, so it was without contrast. So do you see anything that's really concerning?
Kind of like balloons on a string.
Sorry?
Kind of looks like a balloon on a string thing, like a obstruction. or ischemic.
Yeah, definitely. So we see the findings are in the bowel, definitely. So we see the bowel loops are dilated, the oral contrast that was given did not move much. In fact, it is layering. There's so much mesenteric stranding, internal ascites, but more particularly, and when it was read, it was officially read as, since we did not see a transition point definite. So, the blanket approach to similar kind of diagnosis would be infection, inflammation, obstruction, ileus, or ischemia, everything. But when I looked at it more carefully while I was working, so I could see the stomach, duodenum, and then this is the distal flexor. Suddenly, starting from the distal flexor area, there is bowel wall thickening and dilatation. And if we see almost whole of the small bowel loops, they are dilated. At least there is some degree of wall thickening. And if we look at the colon, the descending colon looks pretty good, like it's collapsed. There's not much stranding around it, but definitely there is a kind of distinct point near the splenic flexor where there is certain dilatation of the splenic flexor, and that is continuous proximally into the transverse colon, ascending colon, hepatic flexor, cecum, everything. So looks like this, the effect of whatever is going on is starting from the distal flexor to the splenic flexor. And I was just trying to play with the windowing. I think it's overcall, but to me, it looked like maybe there's a little bit of hyperdensity in the SMA. It's tough to tell. And one history that I didn't give you was this patient has COVID. COVID. So given this patient has COVID and we have this bowel finding starting from the distal flexor to the splenic flexor, and probably I could hallucinate some hyperdensity in the SMA. I called the ICU and then asked, though the patient kidney function is not good, but obviously we need to get with contrast angiogram, at least the arterial phase and the venous phase. So then I was off my shift, and tomorrow, next day when I came in, we could see that was done in the night. And here we can see total thrombosis of the SMA extending from the origin all the way down. This patient was taken to the OR, but since the bowel was already totally necrotic, so unfortunately they could not save the patient. So this case is very sad and unfortunate for 47-year-old, especially in the context of the pandemic. It's very important that we look at SMA. Obviously, as a resident and even as a fellow, I think we do not give much importance to SMA. Like we look at the aorta very carefully. We look at sometimes the small bowel loops is not even on my checklist. If it is grossly abnormal, then I look at it, but otherwise I run the bowel through the rectum, the anal canal, and then go up to the ileocecal junction, and then again run from the esophagus to the distal flexor. But the most important part in the in the GI tract is the small bowel. So it's very, very important that we look at the SMA very carefully, and especially in the context of COVID, we usually think, okay, venous thrombosis are more common, which is true, but for some unknown reason, because of hypercoagulability, though the flow is very high, which is not quite conducive to thrombosis, but still, because of, I think, the cardiac complications with arrhythmias and those things, and probably SMA occlusion is, we have to think about the SMA occlusion. This patient, so we could not save this patient, unfortunately. So there's a nice paper in radiographics by Dr. Pamela Johnson from Johns Hopkins. It's not particularly specific to the COVID, but it gives quite nice techniques and how to scan, and then what should be our checklist. So what I learned from this study was look at the proximal SMA on the sagittal, and particularly distal to mid SMA on the coronal. I think that's the best way to look at the SMA. And I have a question. Have you seen any cases of total celiac trunk occlusion by a thrombosis or occlusion, like acute, not the chronic due to atherosclerosis, but the acute?
Are you saying related to, I have a comment about the COVID thing. In the beginning of the pandemic, the MGH group published a study about the abdominal findings in COVID, and they found in their ICU patients, 30% of them had bowel wall abnormalities. And then, a number of them actually had like infarction in the OR. But like you said, it's usually smaller arterioles. So we know that COVID can give these hypercoagulable things, but it's usually smaller vessels. In our group, we've seen some renal artery thromboses due to COVID. I haven't seen SMA like this, but just, I guess, to know it's possible. And in COVID, patients always look carefully at the bowel. And then your question was, have you seen a complete celiac thrombosis?
Yeah.
I've seen a celiac thrombosis. The major thing with the celiac would be the hepatic artery, but if your SMA is intact and your GDA is intact, you can usually save your hepatic artery. But
that's a confusing statement for me. For example, if celiac is blocked, then we get collateral from the SMA, but why not the other way? For example, if the SMA is blocked here, is it because the SMA obstruction is even distal to the collateral from the celiac trunk?
I think it's because the SMA is just a much bigger, like more extensive network of like that it's feeding, right? Whereas like the celiac, you really need to just save this hepatic artery, which is one tiny artery. I've actually asked this question to my surgeons about why it is they can do an Appleby procedure, but they can't resect an SMA for, like a short segment of the SMA when they're resecting a pancreatic cancer. And they said that like you can't get enough collateral flow the opposite way to fill the whole rest of the SMA.
Gotcha. So only a few facts. So it says regarding the acute mesenteric ischemia, arterial embolus is the most common cause, accounting for almost 50%, followed by thrombosis. So in fact, most likely the cardioembolic source is the most common, and even the location of the obstruction depends upon whether it is embolic or thrombotic. So it says if it is embolic, then it is not usually at the origin. It is usually around 2 to 3 centimeter distal to the origin. So it usually occurs slightly distal to the origin, roughly at the origin of the middle colic artery. But if it is thrombotic, usually atherosclerosis, when the plaque ruptures, it is very close to the origin. So not like our case. Our case is COVID, so all the bets are off, I suppose. Yeah, that's my case. I had another, but I think I'll save it for the next time.
Okay, awesome. Thank you. I'm going to pause the recording.